welcome everyone. I am Lindsay Roosh, a volunteer board member and VP of GADA Canada's board. I will be hosting today, and we've got three panelists with us. I've also got Chris-Anne Campos behind the scenes, our executive director from GADA Canada, who's co-hosting this event and helping me deal with questions and chat. So Chris-Anne is here. I also wanted to take an opportunity to quickly just reiterate who GADA Canada is. I know most people who are on here do know who GADA is, but some people don't. So let's take an opportunity to refresh our memories. GADA is obviously a charitable patient advocacy organization dedicated to providing support and research for individuals living with hereditary or genetic aortic disorders. We're focused on building education, awareness, support, and research for aortic disorders, including running conferences and webinars like this and providing direct patient support and advocacy. We work directly with the medical community and multidisciplinary clinics and our own professional advisory board. We also fund, promote, and founded the Montalcino Aortic Consortium, which is known as MAC, which is an international scientific group associating numerous centers with expertise in heritable genetic aortic disease. We also provide research grant opportunities to numerous relevant research programs in genetic aortic disorders. So today we're going to run through a couple of presentations from our panelists, and then we'll have lots of time for Q&A. The great thing is it lets people send to us questions in advance, so we do have lots of Q&A, but please, at the top or bottom, I think it's at the bottom for our attendees watching, that you can post your questions in the Q&A at any time during, and we'll do our best to address them with you during this event. So, important information. So it's really important that we understand that GADA Canada is hosting this webinar and include all the presentations, discussions, text, graphics, images, and any materials are created or presented by GADA Canada and others in this webinar are for educational and information purposes only. It's important that any content within this webinar should not replace consultations with qualified healthcare professionals for medical advice, diagnosis, or treatment. Give yourself a chance to read this. It's really important that you understand that when you participate in these types of webinars. I also want to make sure you know that none of the information, medications, courses, and any of the treatment or lifestyle or activity recommendations discussed in this webinar should be undertaken without being discussed with your specialists and your physicians. So next we will introduce our panelists. We have Dr. Siddharth Prakash from UT Health, Emma Kate Miller, and Liz Martin. And we will start it all off with Dr. Prakash. Dr. Prakash comes to us from University of Texas Health Science Center at Houston, where he specializes in medical therapy, imaging, and surveillance of patients with heritable aortic and vascular diseases. Dr. Prakash is also obviously a cardiologist and an associate professor of international medicine at UT Health. So please take it away, Dr. Prakash.
Thanks, Lindsay.
So if you just want to share your slides.
I will.
Wonderful.
Thanks, everyone. I want to thank GADA Canada for this opportunity, and Chris-Anne and Lindsay in particular. I'm going to be talking briefly about some work that we're doing at the University of Texas at Houston to define appropriate and answer frequent questions about exercise and activities in patients with various aortic and vascular diseases. In my practice, I frequently am asked about exercise. Here are a few questions that people ask me in our clinic. I have an aortic aneurysm. How can I remain active and live a productive and healthy life? What exercises do you recommend for people who are at risk for aortic dissections? And after surgical repair of my aorta, what activity levels are appropriate? So to understand the answers to this, you really need to understand the idea of risk for vascular dissections of all type. And we know we don't know everything about what causes a dissection, but we do know for sure, based on decades of research, some risk factors that are listed in the slide. In fact, we know that the more risk factors one has, the more likely one is to experience a dissection. And so everyone with a heritable thoracic aortic disease is at some increased risk for dissection, but the risk is not evenly distributed based on these risk factors. The main one, of course, is high blood pressure, but there are other factors that are certainly important, including the type of genetic mutation, whether or not you've had surgery and what part of the aorta is affected, and of course, pregnancy being a major risk factor in women for aortic disease. So how safe is exercise for patients who have aortic disease? The safety of moderate exercise has been validated in small studies in patients with abdominal aortic aneurysms and in patients who have undergone cardiac rehabilitation in several countries. We also know, based on recent studies, that vigorous exercise, moderate exercise is actually beneficial to mice with a Marfan gene syndrome mutation, and because it can actually slow down aortic disease. So these factors all indicate that exercise can be safe in a variety of contexts. So there are some competing risks that many people have heard about. So interviews of dissection survivors based on work by John Eleftheriades at Yale and others have showed that many were engaged in acute vigorous physical activity immediately prior to dissection. So it's certainly true that some types of activity can trigger aortic dissections. The question is, what distinguishes healthy and safe levels of activity from potentially harmful or risky levels of activity? It turns out that the intensity, acuity, and dynamic component of exertion can differentiate beneficial exercise from exertion that triggers dissections. And again, having uncontrolled high blood pressure is the #1 risk factor for acute dissection. We also know that being on preventative medications does lower risk. So these things are very important clinically when you're starting an exercise program. Why is blood pressure in particular so important during exercise? Because the pulse pounding that you feel during exercise is actually physical distension of your blood vessels. And that pressure on the inside of the blood vessels is actually what induces the risk for rupture. If you have an aneurysm, a thin aortic wall, or pre-existing high blood pressure, those blood vessels are therefore put at risk for dissection. And of course, there are other types of risk factors that we can also measure. So therefore, before starting exercise, I ask all of my patients to control their blood pressure. And the target that we work with in aortic diseases in particular is less than 130 on the top, or systolic blood pressure, and 80 on the bottom, or diastolic blood pressure. This is the beginning of abnormal blood pressure as it is defined in the clinical community. So the other important part of preparing for an exercise is to know your risk factors and disease status. Everyone with aortic disease requires lifelong surveillance of some type, but it can depend on your particular risk and the type of disease you have. This includes annual checkups with your physician, regular blood pressure checks, adjustments of your medication if you need it, and of course, imaging. Everyone with vascular disease of some type requires imaging to survey your disease and determine the severity. And the frequency can vary depending upon how it's changed over time. We also know that blood pressure that's measured in the office tells only a small part of your risk. In fact, in 1/3 of cases, there can be significant discrepancies between blood pressure that your doctor measures on a clinic visit and your actual blood pressure at home. The reason for this is because blood pressure varies throughout the day and may not, a single point in time may not capture your entire risk. The reason for this is that there is normal variation during a 24-hour period. This shows how blood pressure changes over a typical day. And you can see that there are peaks in red, there are valleys in green, and at night when you go to sleep, there's a drop or a dip in blood pressure. That means that depending on when you measure it in a single individual, there can be dramatic differences. But it's the overall effect of this over 24 hours that determines the likelihood that you are living with high blood pressure and the severity of that high blood pressure. We also know that people whose blood pressure doesn't drop when they relax or sleep are at increased risk for both complications related to high blood pressure in general and specifically for aortic dissection. So it's not just the average value or repeated values, but it's actually the shape of this curve that also can give us extra information about your risk. So this is an example of an individual in our clinic who had high blood pressure throughout the day that then went back to normal at night. The night is shaded in purple here. And you can see during the day when the person is active, the gray squiggles indicate activity levels. The blood pressure was elevated above that purple square, which indicates the normal level. The red line is systolic blood pressure. So the maximum systolic blood pressure was hypertensive here. And this indicates intact dipping at night, but with hypertension. Here's another individual that has the opposite problem. So this is a graph of someone who during the day, while they're moving around, has relatively normal blood pressures, which you might measure in clinic. But in the purple shaded area at night, when they went to sleep, their blood pressure peaks quite dramatically and becomes hypertensive. This is called reverse dipping, and it's one of the most insidious aspects of high blood pressure, in that your blood pressure can be normal at certain times, but can increase at other times and still put you at risk for complications related to hypertension. Here's an example that's relevant to this discussion. This is exertional hypertension. This is someone who, when they're sitting, has normal pressure, but when they walk around or exercise, their blood pressure becomes very elevated. And this, unfortunately, is rather common in people with vascular disease because it indicates an abnormal response of the blood vessels themselves to activity and exertion. And again, one can't discover this until you do a complete test to evaluate blood pressure in all types of exertion states. So this is called episodic hypertension, and this person has otherwise normal pressure. So by doing ambulatory or walking blood pressures, we can actually determine a patient's risk much more accurately for high blood pressure with exercise than we can with office blood pressures. And this has been shown to be predictive of dissection and outcomes after dissection, such as the enlargement of aneurysms or the need for subsequent surgery. So it has direct relevance to the aortic disease community. This is the most common type of high blood pressure we see in clinic. If you notice, this person has, on the left, has very high blood pressure when they were in clinic, right after we put on the cuff. When they go home, it's normal. This is called white coat hypertension. It indicates extreme anxiety, and it is the most common pattern we see in patients with aortic disease, generally because they're usually afraid of bad news when they come to clinic. And so that means that their blood pressure will be far out beyond what it normally is at home. So as I mentioned, once we diagnose blood pressure, it's really important to treat it. And we can often use medications that also treat your aortic disease. The two main ones being beta blockers and angiotensin receptor blockers. They have different ways that they act in your body, but they both can prevent dissections, and they can also reduce your blood pressure at rest and with exercise. And it's very important to note that most people you've heard about who dissected were not taking adequate doses of blood pressure medication, either because they didn't realize that they had aortic disease or that they weren't being treated for aortic disease. And so that is the major way we can reduce risk of for all types of activity. The other thing to be aware of is that different types of exercise are associated with dramatically different responses of your blood pressure during exercise. The two major types of exercise are dynamic or aerobic exercise on the left and isometric or isotonic exercise on the right. The main difference between the two is that with dynamic exercise, you're moving your body physically through space. And with isometric or isotonic exercise, you're contracting muscles but not moving physically in space. And as you can see, there are very different levels or ways that the blood pressure will rise. Typically with aerobic exercise, there's a steady rise early, followed by a plateau and eventual decline. Whereas with isometric exercise, there can be steep increases as you bear down when you feel that pressure of lifting something. Here, weightlifting being the most common example, but it can be other types of strain as well. In this case, with each repetition, actually what happens is more like the red line here on the right. The blood pressure will go very high and very low in between each rep. And so that change in blood pressure, particularly the sudden change, is what really drives the risk for aortic dissections in those studies that have examined this phenomenon. So to summarize, the risk of exercise is associated with whether you're doing an isometric or isotonic exercise or an aerobic exercise. With isometric and isotonic exercise, your blood pressure increases in proportion to the percentage of your body weight that you lift. The increase is sudden and short-lived. You cannot readily measure blood pressure during these exercises because of the technique and breath holds that are required to do this type of lifting, especially if it's heavy lifting. And so there's a limited opportunity to adjust the intensity of your exercise before you reach a critically high blood pressure that can trigger an aortic dissection. Aerobic exercise, on the other hand, have a more gradual increase in blood pressure, but it may be more prolonged. The increase is not necessarily predictable from baseline blood pressure, as I'll show you. However, the blood pressure can be reliably measured during aerobic exercise, and it provides you with an opportunity to adjust the intensity of your exercise before you reach that threshold blood pressure. And this is an example of a chart that we use with our patients to explain the static or isometric versus dynamic components of different types of activities. This is published and it's actually freely available, but I provide it in a handout to illustrate this. And the important thing is that most people live in the bottom left corner. That is, these activities are both low static components and both low dynamic components of exercise. So you can see that sex is included here, which is a frequent question I get from patients. It's included in the safest tier of exercise that you can do. And so that's why we don't have any restrictions on sexual activity for our patients. But other things like cycling, walking, or hiking are also in this category. And as you get farther out from the left corner, you can see that there's a more strenuous component of each static and dynamic part of exercise. The one thing that we found in our clinic is when we train people, when people train, they can actually lower their blood pressure with exercise. So what we're looking at here is a graph of blood pressure compared to the minutes of moderate activity that people do per week. And we collect this information in a survey before they exercise. And it turns out that for things like cycling, there is a decrease in the maximum systolic blood pressure with exercise as the number of minutes per week of moderate exercise increases by the patients. So with training, your blood pressure with aerobic exercise can drop. When we look at an isometric activity, in this case, a wall sit, where you're tensing muscles but not moving, there is no direct decrease in blood pressure despite the number of minutes of activity per week. So this suggests that it doesn't, for isometric exercise, training doesn't seem to mitigate that effect of increasing blood pressure. We also know that the blood pressure that you obtain during exercise does have predictive effects on your mortality and on the need for other surgery later in life. So this is an example of patients who are being followed for coronary heart disease. They got on the treadmill and they did moderate exercise, and they were followed for 20 years. It turns out that the maximum blood pressure that they can achieve during that moderate exercise predicted very accurately their risk for future cardiovascular events, including the need for surgery. and that risk was greatest in people who had normal blood pressure at rest, which is the non-hypertension group on the bottom there. Those that increased their blood pressure more than around 180 with exercise had a twofold increased risk of cardiovascular mortality over the next 20 years. So this indicates that even with normal resting blood pressure, there can be dramatic changes with exercise that are predictive. What we do in our clinic is we put patients on the treadmill. We measure their blood pressure at 3-minute intervals. And what we're looking at here are two patients that have very different responses. On the top, you see a patient with normal resting systolic blood pressure of 120 who gets on the treadmill, and their blood pressure rapidly increases to 225 within a few minutes. This is exertional hypertension, like I showed you with the other patient. And then it remains prolonged after they finish exercise. The patient on the bottom has hypertension at rest, but when they get on the treadmill, their blood pressure plateaus and declines with exercise. So that patient is actually at lower risk, even though if you looked at them at rest, you would say the person with exercise was less healthy and at higher risk. So the exercise blood pressure response is not predictable from baseline blood pressure. And this is critically important when you're planning your exercise program. And this is another thing that we look at, is how long your blood pressure remains elevated. So I tell my patients to check their blood pressure within 5 to 10 minutes after exercise, and then again out at 15 to 20 minutes. It should be back to baseline by that time. If it's not, that could indicate that they're at higher risk. The other thing that we do is we do some measurements of vascular stiffness in our clinic, and that looks at the way that the blood vessels respond to blood pressure. That can also be predictive. This is called arterial waveform analysis. It's available in some clinics, but not many clinics at this point, but we're hoping that it can become standard for patients with aortic disease, because it has been shown to predict the future risk of aneurysm enlargement and dissection in some small cohorts of patients. And we're hoping to replicate those studies. This is an example of two patients with vascular EDS. One who had a relatively normal vascular stiffness study here that shows relatively normal blood vessels and central aortic blood pressure, and one that had markedly increased stiffness. It turns out that the woman with that had this profile went on to develop several vascular events over the next few years. And so this indicates that you can derive some additional measures that, besides blood pressure, that do seem to be predictive in this population. So the components of high blood pressure are several, and there are still the key players in risk with exercise. We try to measure all three aspects of this: high blood pressure with exertion, walking around high blood pressure or ambulatory hypertension, and vascular stiffness to compute the total risk due to hypertension. And we want to measure and treat all three components to improve outcomes in our high-risk patients. So this is what I tell my patients as kind of a baseline to give them an idea of what they can do. Avoiding the intense isometric components, particularly for patients who've had dissections, is important. And I explain what that is and what it feels like. The most important thing with light to moderate exercise is not to exercise to the point of exhaustion. What I tell people is that they cannot exercise until they cannot do another repetition. If you feel that you're reaching that point, we know that the blood pressure shoots up dramatically, and that is something that you should avoid. We also, if the patient wants to do more intense exercise, we would then do some of the tests that I mentioned to stratify them and make sure that every component is best controlled before they begin a program. And so this is an example of the kind of evaluation we do in our clinic. And we're following patients now to find out if this approach actually improves their quality of life, improves their confidence to begin exercise, and most importantly, preserves their health when they do exercise. So I'm sorry if I ran over, but
that's okay. Wonderful. Thank you very, very much, Dr. Prakash. It's amazing information. I found it very, very helpful the first time I listened to that presentation as a patient. So I think it's like essential, the thing about not holding your breath while you're exercising was like game changing for me. I was like, oh yeah, I can do these things as long as I'm not holding my breath. Like, and just to protect my aorta. So that was like something that I've told my psych, all the different doctors that I'm working with, or exercise physio people, because they just don't know, and we have to take the lead, I think, in our care and making sure we let them know. So now we'll move on to Emma Kate Miller, and Emma is the owner of Body Mason, a Pilates studio in Toronto. Emma is, sorry, I'm lost myself here. Emma is a Pilates instructor and owner of Body Mason, a Pilates studio in Toronto. Liz will also be joining Emma Kate. Liz Martin is a GADA Canada Board of Director, a professional consultant. She also happens to have Marfan syndrome, a genetic aortic disorder, and underwent her own aortic surgery and recovery in the last half of 2020. So please take it away. Do you guys have your video on?
Yes, thank you, Lindsay.
Great.
I do. Liz, I think I do. Yes, my video's on. Okay.
Yeah. Mine's on, and Lindsay, can you see the slides?
I can. It's great.
Great. So thank you so much for the introduction, Lindsay. And that was actually incredibly informative presentation for me as well. It was really nice to hear more in-depth information in regards to this this disorder. So it's going to help for me to speak a lot more to this as we go through as well. So Liz, if you want to just switch to the next slide. I'm going to be talking about Pilates. So when I met Liz, she introduced me to Marfan syndrome and talked a lot about her own personal concerns when starting her program. And one of the points that she brought up was the lax joints. So when we talk about Pilates as a method, we begin close to the joint when we work. We work with really light weight so that we can work on improving alignment, proprioception, range of motion, and build strength at the same time. We talked about stiff muscles. So Pilates is a gentle workout. It can obviously grow in intensity if that's something that you are comfortable with taking it to or working towards, but we do start off pretty slowly and gently because we are really profoundly changing the way that you move. We do work eccentrically, concentrically to lengthen and strengthen. We took to the deep muscles first. So we're talking about deeper, closer to the joint muscles so that your superficial muscles don't have to work as hard. You become more balanced. Muscles feel better with improved posture and range of motion, which is going to go into my point on pain relief. So better posture, better range of motion, and increased strength at the joint means less pain and discomfort. And specifically Liz's story, we're talking about recovering from surgery. So increasing recovery time with pre and post-surgery programs that are built for your specific needs. So when I talk about lax joints, finding a neutral alignment and then strengthening to support that posture or alignment is key. And I'm going to talk about what neutral means in a moment. But when we talk about stiff muscles, we don't typically stretch in Pilates. A lot of people ask me that, do I need to be, stretching before or after a program? We find that stretching is built into the program. I don't even like to call it stretching. We work muscles from the antagonist side. So for example, if you have tight hip flexors, we're going to work your glutes to the back body to help open the hip joint. So that's a safer way to look at balancing out a joint as opposed to just static stretching. And I think it's really effective. I think that there's a lot of studies that I could have mentioned within that, but that's how we look at relieving stiffness. As opposed to a static stretch, it's built into taking our muscles through full range of motion and then working the opposing muscle group. You can go to the next slide, Liz. So what makes Pilates different? So we are talking about a brain gym first. We mean that it's learning about your body and your uniqueness in the way you move and how you move better and safely. So it's a mindful practice. It's about teaching you about where you are. So whatever your natural alignment is, and what does neutral alignment mean? And I often tell my clients, natural is however you stand when you're waiting in line to get your Starbucks. Neutral is what we want to get to. That's our ideal alignment, or closest to neutral. No one is working with a perfect canvas. So Pilates allows you to work within the canvas you have been given based on your life experiences. So a lot of us have other issues on top of our everyday, maybe you've also had a surgery, maybe you've had a hip replacement, knee replacement, spinal fusion. So what are you bringing to the table, and how do we work within that safely? And Pilates allows us to do that. Daytime and lifetime. Pilates allows you to form a better foundation to do your daily activities comfortably for the rest of your life. So it's not about a trend or a fad. We're not going to give you this and then sort of you walk out the door and forget everything that you learned. The idea is with Pilates, you're learning something about yourself and the way you move, and then you're going to apply that to everything else that you do. It's going to be that voice in the back of your mind that says, oh, when I'm getting down on the floor and playing with my kids or going to my tennis game, this makes me feel better. This makes me feel safer when I work. So I'm going to work within that body, if that makes sense. So then we have our 5 basic principles. So Dr. Rakesh was talking about breath, and so did Lindsay. So one of the first, it's the number 1 principle in this method, is our breath. So we teach a specific type of breath. If you've done yoga or other exercises, you might be familiar with other styles of breathing. In Pilates, we breathe in through the nose and out through the mouth. We talk about a 3-dimensional breath, and we use our breath to support the activity that we're doing. So we often exhale on force, but depending on my client's needs, I will ask them to change their breath pattern to make sure that they're feeling really supported in the activity that they're doing. It's also a really great opportunity to slow down, to be more mindful, and to notice how we're moving and how we're breathing. The second one is pelvis placement. So where your pelvis is aligned, our neutral is pubic bones and hip bones flat to the ceiling when you're lying on your back. And so we want to work from that alignment in standing, sitting, lying down. And once we learn that about ourselves, where our neutral is, and strengthen from there, it means that we can take that into our walking and our running, and it makes those things a lot easier. It just builds up from that. So where your rib cage rests, your shoulder, head, and neck placement. And because of these 5 points, it means that if you're working within those alignments, whatever you're doing is going to be much safer. And that's how we teach each exercise. As we address those 5 basic principles, we know that we're safe moving forward. You can go to the next slide. On top of those basic principles, we have these other pillars of the Pilates method. So I mentioned the sort of brain gym. So we're talking about focus, control, precision, alignment, flow, and centering. So if you've ever watched Pilates or done it yourself, you might know that it can look really sort of graceful and smooth, and that's what we're looking for. If we can do something with control, with precision, we know that we're working safely and we're moving profoundly different potentially to how we were. So you want to take this Pilates body with you. You know that your body is going to be moving differently once you have these pillars in place. So based off of those foundations, I have a video that I'd like to show really quickly. So I'm just going to share my screen, Liz. And this is a video of Liz and I working together. It's very slow because that's how we move. And especially this would be Liz, 6 weeks, is that correct?
6 weeks after surgery.
After surgery. So this is Liz at home, and I'm going to just sort of talk over this video. So you'll see I've sped it up because it does move very slowly, but we are talking her through her warm-up, and I'm engaging with her every moment as she works through her breath, as she works into her pelvic rocks. That's what she's doing here, her imprinting and neutral pelvis. So I can ask her how she's feeling. I've added a block between her inner thighs to assist in her pelvic floor awareness, but this is where we're starting. So super safe. You can see I've propped her head. And I'm just going to speed it up so you can see as she moves. So after surgery, lifting her arms was really challenging. So I have her doing all of her scapular mobilization lying down. So you can see her doing her shoulder shrugs. She's doing her arm presses. And then we get into some knee drops. This is where we talk about stabilizing her pelvis. So really gentle, really accessible. There's her little chicken wing circles. She carefully comes up. And because we're working from home, Liz doesn't have all the equipment that I needed, so we is improvised with a Swiffer. So this is where we come to standing to do some range of motion for her shoulders. We're finding her core, and she's just talking to me through this whole moment about what feels good, what feels accessible. And we got kind of excited that that was all moving really well. We took it down and we added it to her floor. So we added some push-ups with the bar, some scapular mobilization here, and then we go to her carefully taking that over her head. So that was a huge moment, allowing for that stretch to happen. And it was a lot more work than we thought it was going to be. Now this is Liz at week 3. So one of Liz's main goals was to do a chest curl or an abdominal curl. And we didn't know when that was going to happen, but we were building up to it. So now you can see a very similar version of what we just showed, but now I've added resistance. So she's able to do this now with her TheraBand. I'm going to speed it up just a little bit so you can see. So she's doing the same reaches, adding some leg lifts. So this is where we added coordination, a lot more work through her core. And then I propped her with the band so that, because Liz at this point still couldn't get her hands all the way back behind her head, propping with the band allowed her to modify, and she went right into her chest curl, which kind of blew my mind. Liz?
Yeah. So this is 9 weeks after my aortic root replacement surgery. And I was just really stiff because I had not really been moving my chest, and it was really, really hard to get up off my back for many, many weeks. And I just hadn't been moving the way I was used to be moving. So this was a really big thing for me to like realize that, yes, I could move from the center of my body and lift my own body weight up like that. So that felt like a big achievement.
Yeah, it was huge. And so we can talk a little bit about the 5 basic principles here as well. So Liz is in her neutral pelvis, meaning she's got a little pocket of air in the small of her back. She's flexing her spine forward, but you can see her head is in line with the rest of her spine. So she's not picking her head up off of her mat. She's allowing her spine to round forward and take the weight of her skull in her biceps in a position that felt way safer for her there without having to do that big reach behind the head. So big moment. And then I just wanted to show you, here is Liz today. Now, months since her surgery, and we are now working on, this is her about to do a side plank. So we went from not being able to lift her arms to now weight bearing and holding her beautiful side plank. So I know Dr. Prakash had talked about isometric exercises. Here's an example of that, but we are not doing a huge amount of reps. Liz can, rest at any time. and she can decide how she's feeling. So I think at one point she does bring her arm up. We could add weight to that arm if we wanted, but yeah, just super proud to see how far Liz had come. And we just are going to finish. I'll just show you, maybe I'll speed it up. So here is now Liz doing a mermaid, which is also super huge. Her range of motion has increased obviously dramatically, being able to take her rib cage through those beautiful side bends. It's great. So that is our cute little demo. I will stop sharing and go back to my slides. I think we had a cute little Joseph Pilates up there. So there's Joe and his famous little shorts. And it's just a famous quote that everyone says. I don't know how true it is, but I think that in Liz's case, this sort of spoke kind of volumes. In 10 sessions, you'll feel the difference. In 20 sessions, you'll see the difference. And in 30 sessions, you'll have a whole new body. So this slide is just to talk a little bit about some of the myths that I hear within the Pilates world. So often people will say, oh, it's all about abs. It's for older women. It's for ladies who lunch. It's just like yoga. Or you have to be super flexible to do Pilates, and none of these things are true. It is none of those things. It is all about the core, but we never have to do an ab curl to activate the abdominals. We can work in a million different positions to find your core safely that don't involve what that woman is doing on a bench. Similar to yoga in that we work on a mat. We also work on different equipment. Pilates does have a series of exercises that we do, but within that there is a multitude of modifications and variations that are built to fit every type of body. So it's really accessible in that way. And like I mentioned at the beginning, flexibility has nothing to do with it. We don't need you to pretzel yourself like that gentleman. We want you to work within a really healthy range of motion. So what is my next slide? So why is this important to you? So I've said some of these things already. Accessibility and flexibility to work with everyone and anyone online. And obviously Liz and I do one-on-ones. And when I mean online, I mean because we are in a pandemic, in a group class setting online. Pilates is the bridge to overall health and translates to everything that we do. It's about educating you and your body. So we talked about neutral versus natural body alignment. So the more you know about yourself and how you move and the safe way to move for your body, I think is huge. It's also going to really empower you to make decisions for yourself and your activity. And it's personalized. So we use props and modifications for a safer, better, and faster result. When I say modifications, sometimes people think that means an easier version, and that's not often the case. Modifying an exercise can often just mean working better and more targeted. So you're actually doing the exercise properly and better to get to exactly it is that we want from the exercise, as opposed to stressing or straining. For example, in the video, Liz doing her abdominal curls, having that band behind her head didn't change the effort of the exercise at all. She was still doing a full chest curl. It just meant she didn't have to have the weight of her arms or that reach of her arms behind her head. And I think that better physical as well as mental health is super important. So having that confidence in yourself to know you are physically capable and is really great for our mental health. Just a little bit about my studio. Body Mason is about building up, not stripping away. It's about gaining an understanding of your individual structure and mechanics while increasing strength and balancing health. And that is it.
I just wanted to say a few words about my situation to put to put my story into context in my work that Emma Kate has talked about here. So it was mentioned that I have Marfan syndrome. So I came to Pilates about 7 or 8 years ago. And that was after I was continually struggling with repeated injuries to my neck and my upper back and my shoulder. I worked a desk job. I didn't get a lot of exercise. I've never been very athletic. I've always been very clumsy and not very aware of, of my limbs. So I've never really been very inclined to be physically active. I jogged and I walked because that's what my doctors told me was good for me to do. But even with that, I found that it was hard to keep up with it because I was always injuring myself with Marfan syndrome. One of my biggest symptoms is musculoskeletal issues and having lax joints and having weak muscles. So I found even with walking and jogging, I was always like putting out a knee or putting out my hip. And I was really struggling with that and thinking there's got to be a better way. There's got to be some way that I can keep myself active, but not be hurting myself. So I came to Pilates after going to physio and having a physiotherapist tell me that I really actually needed to strengthen my muscles. So then I started looking into Pilates. And then I came to Emma Kate's studio 3 years ago. And when I met her, I told her about the things that I was looking for and the things that I wanted to focus on. In my case, I'm not high risk for a dissection in a lot of senses, in that I have very low blood pressure. I'm on beta blockers. I hadn't had an aortic surgery until just recently. So it was fairly low risk and kind of knew what I could manage and do. But at the same time, I also told Emma Kate, you're never going to see me in one of your power classes. What I want to do is I want to work slow and deliberately and focus on these problems that I keep having, like putting out my hip. I want to strengthen my hips so that I can walk with ease. So that was our focus. And over the years, she's gotten to know me and she's gotten to realize, gotten to know more about my body and know about the modifications I need, such as I have a Tarlov cyst at the base of my spine. So when that got worse, I needed to let Emma Kate know I need modifications. I can't always be rolling back on my pelvis. So I found that working with her and using Pilates has been really great for being able to personalize everything and take everything slow and customize all the exercises to exactly what I'm needing. And when I was gearing up for my surgery, my valve sparing surgery last July, I let her know that. And we kept up with our regular routine. But then we also started thinking about, okay, what are things going to be like after surgery and how are we going to slowly ramp things up? And so I met with her one-on-one, as you saw in those videos, after the surgery to get me back on track so I could get back to my usual routine.
And now you're right back into group classes and are able to make those modifications for yourself.
Yep. All right, I think that's our spiel. Lindsay, do you want to do Q&A?
Thank you very, very much, everybody. I'm just gonna stop. Can you stop sharing your screen? And then we will move into the Q&A. So this is what I wanted to just point out, that the Q&A is at the bottom of the webinar portal. If you look in it, Dr. Prakash has very nicely answered lots of the questions, which are amazing answers. So please have a look at that. There's some really interesting questions specifically about exercise, medication, and what movements or things, for example, do make your pressure go up, which is obviously one of the big areas that we're worrying about. But I wanted to also ask the group a couple of questions that came in prior in the registration. So one in particular that's more sort of Pilates related is about doing it with spinal fusion. We did get a couple of questions about people who want to increase their core, but they've got a fusion. So what are their options with movement? And, you know, of someone who has a spinal fusion myself, and I've, you know, been doing a little bit of Pilates, it just means a modification. And I'm assuming that's what, you know what I mean? And working with an instructor.
Absolutely. Yeah. I was talking about neutral. So we have neutral spine as well, not just pelvis or ribs. It's sort of a term that we use for each part of the body. So when I have clients that are looking to not be flexing or extending or rotating, you can work within a neutral alignment, being flat on your back or hands and knees, or as Liz was in her side plank, maintaining those natural curves or the curves that you've been given from your fusion. You can still strengthen your core within that place, or by taking your arm as a longer lever away from your midlines. That's going to create that challenge for your abdominals. As you saw, Liz was doing those little leg lifts in the video. Those were all for pelvic stabilization. So we didn't have to do crunches at all to strengthen her core.
Right. A couple of other questions. Obviously, there's always that, I brought that before, about breathing and planking and holding your breath. But also, we do have some people with us who are living with current type B dissections and obviously are medically managed. And just that worry about doing any movements or exercises that might, you know, damage or progress it too quickly. And so I was just wondering if Dr. Prakash, you could address that.
Sure. So dissection survivors are no doubt a high-risk group for a couple reasons. There's a concern about developing an aneurysm after a type B dissection. And then on top of that, you can also develop other vascular complications. So for this reason, we do recommend that everyone who's contemplating exercise, particularly if you've never done it before, have a thorough evaluation by a physician before you start any sort of new exercise program to address those conditions that we talked about. Make sure your blood pressure is optimized, that you're on a preventative medication, that you know the disease status is not changing, because if any of those things are changing, you probably need to wait until they're stable before you start an exercise program. Aside from that, we do see that there is great benefit to people who are able to maintain their activity levels, particularly with aerobic exercise. We know that it can be safe and effective, even in patients with dissections under these controlled circumstances.
Great. This was a good one that came on just because it made me laugh, and I just kind of want to ask you this because, you know, I'm a little bit kooky that way. Is hula hooping safe as exercise with someone with an genetic aortic disorder? I'd like to know.
Well, I have been asked that before, actually. I've been asked very specific things about different activities, and I find no reason why, particularly if someone doesn't have significant musculoskeletal limitations, that hula hooping wouldn't be a great, a great activity for someone. It is, it can be very effective. I think, that would be the major limitation, as far as I know. We certainly haven't measured anyone's blood pressure while they were hula hooping, but I can't imagine it would be too different from other types of activities we do measure.
Yeah. And then, again, what are sort of the best exercises? I know you shared that slide that really does highlight sort of those mild to moderate exercises that are, the most for this category. And obviously that's why we're highlighting Pilates as a way to move and also stabilize. There are lots of people with different gene mutations that do require some extra support of the joints and tissues because of having, connective tissue disorders, and exactly why Liz herself has been taking on to Pilates and supporting the body so that you can live your life. And I think that's the part of it that's most interesting, is that it's about staying well, not just aortically and cardiovascularly well, but physically well in order to live your life. So what about cardio boxing or kickboxing?
Oh, well, that's a slightly different category because now we're talking about potential contact sport. If you're contacting an inanimate object like a punching bag or another individual, there is a risk for trauma, and that trauma can be significant depending upon, the force exerted. So we generally discourage those types of activities just because it's quite unpredictable, and it only takes one impact to potentially cause aortic trauma in a dissected aorta. So I do caution against contact sports when I tell patients about activities in general.
Here's another interesting from somebody who's with us today, which is, would outrigger paddling be considered high risk exercise?
Right. So in that diagram, there actually is rowing or paddling. It's listed as one of the more vigorous activities that you can do. It's vigorous on the joints. In particular, if you've ever done a rowing machine, you get a full body workout from that. So it is considered quite vigorous in most situations, unless you were doing significant modifications. You would really have to get into the specifics about it, how long, how intense. But in general, I would say that would be beyond the scope that we would normally feel comfortable with.
And what about, I know that we do have some bicuspid valve disease people in this community of people who've had aneurysms or dealt with other issues with their valves. And are there other exercises that, is that a different, because I'm obviously not as aware about, you know quite a bit more about bicuspid valve disease than I do. So I'm just interested to know, is there a different approach for exercise for that community, or is it very similar to the aneurysm dissection aortic management?
Right. So in most cases, bicuspid valves don't cause significant symptoms. If they are, if someone is significantly limited by their valve, then we can do something about it and make them feel better. So in that case, I would say fix the valve if it's causing a significant lifestyle limitation, and then get back to your exercise because it is correctable. But otherwise, I would say there's no significant difference.
Right. And how about bone density? Emma Kate, do you know about Pilates and you know what I mean? And the value of, I know some people as they're aging, whether you have a connective tissue disorder or not, you're still going to be concerned about age and bone density. And I'm just wondering if Pilates sort of helps with that.
Absolutely. There are actual bone building Pilates classes. There are some teachers who have specialized specifically into just bone building Pilates. There's tons of stuff online. You can YouTube bone building Pilates classes. There's some incredible women that have been really gearing their class towards that. It involves a lot of standing, but it's so low, like it's really accessible as well. So I would say absolutely you can find bone building specific, but I would also stretch. I mean, this has happened many times where someone has called me up and said, "Hi, I've heard that you teach Pilates. I need to come to you to, help with I came for the posture class. Like I want the posture class." And I was like, "The what?" It's just Pilates. It's just the Pilates part. But when you hear about, oh, it's really great for it's great for posture, it's great for bone building, we start to think that there's a specific thing. It's just the actual method itself, but you can gear it if you would like to specifically bone building, but standing Pilates is great for that.
Great. We've had a couple of questions about stretching, and obviously somebody like me who has a connective tissue disorder, I'm quite hypermobile. And, when I've done yoga and stuff in the past, I can do some pretty flexible stuff, which I probably shouldn't have been doing purely because it was extending me and my joints and tendons in a way that was probably putting a little bit pressure on the joint. But because I could do it, I would just do it. Whereas it was something that I wanted you to talk to also, Emma Kate, about making sure that when you're people who have certain genetic mutations, we don't want to stretch too much, but we also want to get the movement. So how can we address that?
Absolutely. So as I mentioned before, we don't stretch in Pilates. There's no static hold a stretch. There are definitely long levers that we do with some of our exercises, but we don't need those to be the exercise. So bending our legs or bending our knees so that we are making our levers shorter. Also working in, I know I've said it again, neutral. So knowing what neutral alignment is in yourself, especially if you're someone who is hypermobile. So for me, I had really hyperextended knees. And so I did not know what that meant. And I thought that standing straight was me at my end range of that hyperextension. And that's a not great place to work. So learning how to unlock my knees, finding what a neutral alignment at my knee was, what with my proprioception involved in learning that, and then strengthening around that place took some time, but just with, that mindful practice, like anything, I learned how to figure out, okay, what's my hyperextension range? What's my neutral range? And where's a bent knee? And then knowing those 3 points, working within that. And if I do want to stretch, then I know that I'm going to work the opposite muscle group. So if my hamstrings are tight, working my thighs, the fronts of the legs, those quads is just going to be enough. We don't need to reef on a joint and really, you know what I mean? It can be really, really gentle and accessible.
Wonderful. Thank you. I also wanted to, someone was just asking actually about golf, and I think Dr. Prakash was answering it about twisting and golf. Well, can it give you a dissection? So can you just answer that one live?
Yes, I actually have several dissection survivors who play golf. They do fine with it. As long as you don't try to hammer the ball. Said don't hit it 500 yards. If people can do that, it's fine. And there is a lot of, if you don't use a cart, there's actually a lot of walking. So I do think that if people enjoy doing that, I encourage it because it gets them outdoors and walking and makes them feel relaxed. Overall, it seems to be a very healthy addition to the lifestyle.
Wonderful. Okay, so I think I've covered most of the main categories of questions. As I said, there are some that have already been answered in the Q&A. We'll also, if anything doesn't get answered because it was a little bit too specific or was outside of exercise questions, we will also make sure we answer things directly to the attendee or through an email from GADA Canada. So if you thought that maybe we missed your question, there are some that were even pre-sent in that were a little bit outside of the exercise webinar. So we will answer your questions just outside of this webinar. I wanted to also mention that this has been recorded and there will be a replay. It will be on GADA Canada's YouTube, and we will let you know when that's available. I also wanted to make sure that you can follow up. We're going to put together a tip sheet of all of the tips on exercise and blood pressure, and also working with an instructor to find somebody who would be helpful to do this type of exercise with. We've sort of identified that that's the key, is finding someone who you can almost give your information and then they can modify the exercise for you. And I think just going and getting a DVD and trying to do all the exercises aren't the right choice. So that's why we're just encouraging to work with a practitioner or an instructor who really knows what they're doing. And you can also provide the information from GADA Canada, from Dr. Prakash about how to do it safely. And these are my issues and my risks, and we need to work around those. So I think that's just really, really important. GADA Canada, we're also going to be providing some additional webinars coming up. So I wanted to just sort of touch on a couple of those things that are coming. So in case you're interested, to keep an eye for that. We're working on one for issues related to eye complications for those with GAD, which is genetic aortic disorders. family planning concerns, which is definitely that comes part of it, especially if you've had an aortic dissection or you do have a genetic aortic disorder. Quality of life approaches. Obviously, exercise is part of quality of life, so this already hits one of those, but there are some very specific things that we would like to address. Addressing more anxiety and depression as part of having a dissection or living with a genetic aortic disorder. And some specific sessions for those with ACTA2 gene mutation and some of the more rare gene mutations that have recently been identified, and about more information about that from experts and how to approach living with those new diagnoses. I also want to just to close us up. I'll just finish off, and then if you guys could say whatever you'd like to say at the end, and we'll be good to go. I just want to reiterate that none of this information, any medications we talked about, courses of treatment, or lifestyle and activity recommendations discussed in this webinar should not be undertaken without discussing it with your physician, your cardiologist, or your specialist. It's really important to make sure that that we're all aware of that. So thank you for our panelists. It was amazing content. I'm thrilled to share this, and GADA Canada is just beside itself to be able to deliver this to our community. So thank you all. Do you guys have anything else you'd like to add?
Thank you so much for having me.
Thanks for having me. Thanks, Emma, Kate, Lindsay, and Liz. It was terrific. I really learned a lot myself.
Great.
Thanks, everybody. And as Lindsay mentioned, I'm on the board with GADA. And so if anybody has any questions, feel free to reach out to GADA and they'll get to me if I can answer your question.
Exactly. Wonderful. Thank you, everybody, and have a good evening.
Bye.